Hey everybody, welcome to the protocol update. We're covering the protocols for the advanced providers in this section. Some basic concepts. These are very similar to the concepts that we went over for the basic life support providers and the BLS protocols. Basically, protocols should be good medicine. Our protocols are. Our protocols are well founded in the evidence. We want to make sure the right decisions are being made to take care of our patients. Also, our protocols are following the National Scope of Practice model. There are a couple of areas where we differ from the National Scope of Practice model, but we do so based on good medicine, and we do so based on the needs of New York State. Our protocols also are founded in common sense. We want to make sure that we're supporting our providers as they take care of our patients, and we make sure that our system has as much integrity as possible. These are going to guide quality care. And we need to remember that basic life support and advanced life support are a continuum, and that care starts in the field and continues right through into the hospital. Frankly, it begins right after the injury, at the time when our professional emergency medical dispatchers first take that call, begin giving pre-arrival instructions, right the way through rehabilitation after medical care in the hospital. So it's a long continuum, and we're a really strong part of Chapter 1. These new protocols are getting closer and closer to becoming guidelines and not recipes, because we recognize that we can come up with as many numerical protocols as possible, but patients don't read books when they're having their disease process. So what we want to do is make sure that we're giving the best care that we can in as reasonable a fashion as possible and guiding providers to care for that patient correctly. There are a couple of protocols that very specifically authorize providers to do the right thing. We want to make sure that our providers feel comfortable taking care of patients and doing the right things for that patient. At any time, if somebody has a question as to what the right thing might be, then they should call medical control and have a discussion, and we can help. The other thing that's really important throughout this protocol and the basic life support protocols is there's an asterisk in many sections where it says if equipped and trained. We've added many things to the protocols that are not required equipment for every agency, because it may not be operationally reasonable for an agency to be equipped with all of these tools, although in some settings they may be useful for patient care and appropriate for that agency. What generally was added for critical care techs and paramedics? Well, fever and pain management can be treated with ibuprofen and acetaminophen. That's what people do at home. Well, if we can do it at home, we can do it in an ambulance as well. So these are both going to be options that are available across the board. But it's really important, these are not to be treated with multi-patient vials. If you open a container of acetaminophen or ibuprofen to take care of a patient, that then becomes medical waste. That's no longer supposed to be on the ambulance, right? Everything that's on the ambulance should be sealed. Ketorolac, or Toradol, is now on standing orders. We want patients to get the best care they can get. In this case, it's the opportunity to reduce opioid use. And we've also found out that Ketorolac works well at a lower dose. We'll spend more time talking about that later. Amiodarone boluses don't need dilution anymore. Found out it probably doesn't make any difference, and it was just contributing to workflow issues during cardiac arrests or with sick patients. And we have new pediatric protocols, including ones for what we're going to call an apparent life-threatening event or a brief, resolved, unexplained event. We also have a new protocol for technology-assisted children. The pediatric definition in 2017 talked about human development as a continuum. And we talked about pediatrics being children without secondary signs of puberty. This became just too confusing. So what we wanted to do was simplify this, make it as easy as possible for our field providers, and we changed this instead to say that pediatric protocols are appropriate for patients who have not yet reached their 15th birthday. Look, we all realize that 14-year-old children don't carry driver's licenses with their date of birth on them. If we make a mistake and we take a big 14-year-old and treat them as an adult, that's okay. As we said, general guideline. What we want to make sure we're doing is providing the best care for our patients as often as possible. The way to think about that, if you're using a weight-based drug, that weight-based drug has a maximum dose of whatever the adult dose is. So if you do treat that 14-year-old child with a weight-based drug, but they weigh a lot, the adult dose is the maximum. Right? I hope that makes sense. If you're using a weight-based drug administration, the maximum dose is going to be the adult dose. As always, we recommend either a length-based resuscitation tape or other device that will allow you to calculate out dosing for small children. We want to make sure that we're dosing our children appropriately. We realize that there are some inaccuracies with length-based resuscitation tapes because American children are large, but that will underdose a child, not overdose them. So length-based resuscitation tapes are the standard unless your agency or region has a different device that you've standardized. General approach to the EMS call has been added in. The idea is that this provides a framework for approaching a call, and that's a reasonable thing for us to start with. We ask people to consider dispatch information, survey the scene. It's all the things you're already doing. This is in there to standardize the protocol, not to provide extra work for the EMS provider. General approach to the patient is in, specifically to make sure that we are putting into the document, the protocol document, the way that we expect patients to be taken care of thoroughly, appropriately, and based on the disease process that it's presenting. Basically, what we've written down, do what you're already doing. You're already providing great care. This is just putting it on the document. Safety restraining devices. We want everybody in an ambulance to be restrained. Why do we want people to be restrained in an ambulance? Because it's safer. Children must be restrained. We are very clear in our language that children are not to be sitting on the lap of a parent or a caretaker. Kids should be in a safety seat. They should be in a specific pediatric restraint device. And agencies should consider how to do this as safely as possible within their budgetary constraints. We want to make sure children are transported safely. Consider ALS is in some protocols, but not in all of them, because it's just a part of that continuum of care. They should be a part of it depending on the system itself. Transport should be to appropriate facilities, and really importantly, we put into the protocols to consider the use of warning devices because lights and sirens are a medical intervention. Think about whether or not the patient's condition warrants the use of lights and sirens, because that is the time when our providers are at most risk, and so is the public. Above all, be safe. I'm going to stop here, and I am going to turn over to Dr. Cordi, and she's going to pick up and run with care. Thank you.
Thank you, Dr. Dailey. Thank you, everyone. We're going to continue on now with the guideline for pediatric cardiac arrest, of course, to consider intubation only if unable to effectively ventilate. Remember, you're always doing your BLS skills anyway prior, and you're going to do it throughout even the cardiac arrest. We care that you are able to effectively ventilate with a BVM and basic airway adjuncts if available. Here again, as per our protocol, that has not changed, that we're going to be defibrillating, giving amiodarone, and remember what Dr. Dailey just said, we will not need to dilute it. We will be giving defibrillation, but we will no longer be doing dual sequential defibrillation in our cardiac arrests. Termination of resuscitation in instances that are only covered by standing order criteria be authorized by medical control. Once again, you can call one of your REMO physicians and they can help you with that. Respiratory arrest and failure for treatment of patients with absent or ineffective breathing for all skill levels include the signs of ineffective breathing, such as agonal breathing, and provides basic treatment guidelines for patients that are conscious and can breathe, cough, or speak, conscious and cannot breathe, cough, or speak, or unconscious. Key points again for the respiratory arrest failure in both adult and pediatrics is, of course, not delaying transport, and especially for the child, because the child with a partial obstructed airway, when they are agitated, and you can still appreciate that they might have a foreign body stuck in their throat, that any amount of agitation can lodge that foreign body further and occlude the airway. So we need to limit our interventions that may cause unnecessary agitation in the child. In termination of resuscitation, we should consider the end tidal CO2 when discussing termination with the medical control physician, and also looking at the extremis and obvious death protocol, which was provided as well. Looking at the child, the apparent life-threatening event, brief resolved unexplained events. These are particularly confusing when the child looks well, but we can't figure out what happened during that time. And these episodes usually occur in children under 2 years of age, and it's frightening to the observer, of course, and it's now resolved, and characteristically, patient might have had a brief episode of apnea, their skin color might have changed, there might be some change in their muscle tone, choking or gagging or any seizure-like activity, and this usually lasts for less than 1 minute. Need to assess the patient and treat as appropriate, and they might look stable to you, but there might be signs of underlying illness or injury. So transporting the patient to the hospital might be in the patient's best interest. Paramedics, of course, for the adult anaphylaxis can substitute albuterol alone in place of a combination of albuterol or ipratropium, and you can repeat that for up to 3 doses. If the blood pressure is below 65, consider norepi at 2 mics per minute and titrate that up to 2 mics per minute if needed after you complete a fluid bolus. We here would like to maintain a blood pressure, a systolic of greater than 100 millimeters mercury, or a systolic mean arterial pressure of 65 millimeters of mercury. Do not give the IV epi without consulting medical control first. For carbon monoxide poisoning or suspected patients with smoke inhalations, patients for whom a CO alarm has gone off, or any other potential exposure, all patients should be receiving high-flow oxygen. That's because the oxygen at higher concentrations will help to get rid of, if you will, the CO that's attached to the hemoglobin. So if you start that oxygen early on, especially high flow, you give the patient a better chance of recuperating much faster. We also want to make sure that the patient does not have any soot or black material in the airway, and you'll be able to apply CPAP as available. For the older pediatric patients, consider CPAP as equipment allows, and if available and if trained for such. For the adult chest pain patient, of course, vascular access, and refer to the general pain management adult protocol as indicated. Here you have nitroglycerin, 0.4 milligrams sublingual per dose as needed, Q5 minutes apart, provided the patient's systolic blood pressure is 120 millimeters of mercury or a MAP of greater than 90 millimeters of mercury. What's new to the collaborative protocol is the pediatric cardiac-related problem, and of course that's also a scary thought. It offers general standard of care guidelines, and here we have the systolic hypotensions for the different ages, 1 month, 1 year, and ages 1 through 10 years, of course, and provide with a formula for 1 to 10 of 70 plus twice the age, or 1 year less than 70 or less than 1 month 60 millimeters of mercury. For the diff breather, including asthma, COPD, and the wheezing adult, vascular access, of course, epinephrine dose of 0.3 mg IM for severe distress, and if this severe distress persists, you can repeat in 5 minutes. Albuterol, which is given in a unit dose via nebulizer or even endotracheal tube nebulizer, can repeat it for 3 doses for wheezing. And when in doubt, always feel free to call Remo Doc as well. The paramedics in the CC may substitute the albuterol unit dose and the Atrovent or the ipratropium 0.5 in unit dose mixed together via the nebulizer or endotracheal tube nebulizer for albuterol only above, and may repeat also up to 3 doses of medication for wheezing. And of course, monitoring giving Decadron or dexamethasone 10 milligrams, either PO, IM, or IV. They've all been found to be effective dosages. And for the patient with asthma, if they're not responding to the treatments above, giving 2 grams of MAG over 10 minutes. For the diff breather, continued with additional albuterol unit dose via nebulizer, and then magnesium is now added for the COPD exacerbation. For the patient with difficulty breathing who's having a pulmonary edema exacerbation, patients can receive nitroglycerin as an option for the advanced provider. And here we have the epi auto-injectors for the diff breather who is an asthmatic and the pediatric patient. Remember, they have up to half of the dose of the adult, and the epi auto-injector has been made a medical control option now for the advanced EMT. Consider CPAP for the older pediatric patient as equipment and size allow. Here's a new one for us, and it's a fever protocol for both adults and children, and those include acetaminophen. Those contraindications are liver disease, and ibuprofen. The contraindications are renal disease and blood thinners. And here's what we were talking about also with children with fever, talking about the maximum dose. We know that acetaminophen and ibuprofen are both administered on a weight base for pediatric patient. With your max dose will be now the adult size dose if the child is more than 30 kilograms. Here, looking for the airway breathing circulation, of course, starting in IV with normal saline, of course, concerning for pulmonary edema if the patient has a history. But if the patient can tolerate oral, consider giving them acetaminophen, 650 milligrams PO, and ibuprofen, 400 milligrams, and the unit doses that are provided on your service. For vital signs, including for the pediatric patient again, if you can tolerate fluids and you can't get the IV, here we have a nice layout for us, a nice graph that you can find the child's weight in and appropriately dose the acetaminophen or the ibuprofen. In a pediatric hypoglycemic patient, if you are unable to obtain the results with oral glucose, giving glucagon 0.5 milligrams if less than 20 kilograms, otherwise 1 milligram IM if needed. Again, to the overdose patient, only give the Narcan to patients with suspected opioid overdose, with hypoventilation, with ineffective respirations that are slow and shallow. And for provider and safety, do not minister without medical control order if there are adequate ventilations. And for the advanced provider, remember IV only if necessary. Titrate the Narcan, 2 milligrams per dose. Divide that in half in each nary if you're giving it that way. And consider giving less than 0.5 milligram intervals if you're giving it by IV. For those symptomatic organophosphate exposures, the pediatric patient can receive atropine, 1 milligram IV, Q3 to 5 minutes until secretions dry up. That is new to our protocol as well. For the adults, we've been giving it Q3 to 5 minutes until secretions dry as well, but that's a 2 milligram dose. For pain management, As we said, we've now added acetaminophen and ibuprofen. That has been put into these protocols as well for you, just as the dosages were given in the fever protocol too. And now we also have ketorolac or Toradol, which is given 15 milligrams either intravenous or 30 milligrams intramuscularly. Nitrous oxide also, if available, can be self-administered inhalation to control pain, in addition to oral fluid, giving either acetaminophen or ibuprofen per appropriate weight-based dose for the pediatric patient. For sepsis, septic shock, hyperperfusion in the pediatric patient, patients with hyperperfusion either because of trauma, bleeding, vomiting, diarrhea, or sepsis. And in the septic patient, the patients who have a fever greater than 100.4, high respiratory rate, temperature is less than 96.8, and a high heart rate or poor perfusion, need for oxygen, and altered mental status, or the child is irritable. So remember, we like the forewarning, of course, so we can get some stuff ready for your arrival to us for the patient. So when you're following vital signs and noticing the trend, and giving us a call. And we appreciate it if you are able to gain vascular access and then appropriately fluid bolus your child of 20 cc's per kilogram, and using normal saline 100 bag. Of course, if the patient weighs less than 20 kilograms, less room for error that way as well. Continuing on, we have the key point and considerations. If you are concerned, consult us if the patient is suspected to have cardiogenic shock. Do not use the 1 liter bag for pediatric patients, again, if they are weighing more than 20 kilograms. Diagnostic indications for hypoperfusion: think about your patient when they're feeling cool and clammy to you. They're not recognizing their parents, they're restless, listless, they're tachycardic, tachypnic, they just don't look right to you. Remember, you got to trust your gut feeling too, and your parents or the care provider when they're saying, my child is just not right. Here again are your vital signs defining for sepsis. And remember, a key point too is that blood pressures can be really difficult to obtain in infants. So looking at their respiratory rate and their pulses, that can be a little bit easier measured. And of course, letting us know once again so we can prepare to take care of your patient upon arrival. Now thinking about our children with technology assistance, patients that have a tracheostomy, that's the breathing tube in the neck, central venous catheters, tunneled, Broviac, Metaport, the PICC line, catheters that enter a large vein by central access, the VP shunt patient with CSF shunting, the internal tubes, the gastrostomy tubes, the PEG tubes, the Mickey buttons, the J tube, the colostomy, ileostomy, ureostomy, nephrostomy, Foley. These are all a nidus of infection too. So just a forewarning, if you think that that patient might be septic and they have a tube. But what else do we want you to know about that? If it looks like it might be coming out, tape it in place wherever it is. Tape it there. Don't pull it out. Don't try to push it back in. Tape it and transport. So these patients also require frequent vital signs and blood pressure. And remember, always listen to the caregiver. They know their child best. Looking at the technology-assisted child presence of a patient care plan, syndromes, diseases. These parents and caregivers know a lot about their patients. Some of them even come prepared with a notebook if you haven't already experienced that. They may have unusual vital signs. They might be hypoxic at baseline for us. Their symptoms, what's different today? Ask the care provider what's different, why they called EMS. What about the best way to move the child? Sometimes we can't lie the child flat when we transport, but we still have to secure the child in the back of the ambulance. Look for any medic alert jewelry, any information forms, patient care plans, any form that might be available. And take this consent with you and bring it you to the hospital. Assess and communicate with the child based on developmental, not chronological age. Take the necessary equipment with you, no matter what it is, to the patient or the hospital if possible. For the patient with the total artificial heart, the TAH if you will, if the blood pressure is greater than 150, you're going to give patient sublingual nitro and repeat the vital signs. Look for hypovolemia if the blood pressure is less than 90 or anything that might be consistent with distributive shock. You will also give another bolus of 250 cc's, total up to 1 liter if hypotension is persistent, and you feel free to contact medical control for additional boluses. It's not necessary in this case to apply the cardiac monitor or perform pacing or defibrillation, and do not give vasopressors or antiarrhythmics. For the bleeding pediatric and adult patient, remember junctional tourniquets, wound closure devices, and other hemostatic agents may be used in accordance with manufacturer's instructions if regionally approved. For burn patients, especially for eye, we'd like you to instill tetracaine, a numbing drop, two drops in the affected eye for pain every 3 minutes as needed. And for chemical exposure to the eye, you can use a Morgan lens, which looks like a contact lens, for irrigation. For chest trauma, if the patient is in cardiac arrest, proceed with bilateral needle decompression and refer to the appropriate arrest protocol. Thank you for your attention.
Guys, just remember the needle decompression. That was in addition for the advanced EMT. All right, we some questions to whether or not we should be doing that or shouldn't be doing that, and just then add it back in as they just their arm. So I'm a little scared about having the harpoons out